Welcome to this explainer. Today, we're going to dive deep into a precise, step-by-step clinical breakdown of the entrapped fourth ventricle. If you've ever needed a clear, visually grounded walkthrough of exactly how this condition develops, how it presents in a patient, and how it's ultimately treated, well, you're absolutely in the right place. Let's get right into it.
We've got a lot of crucial ground to cover. We'll be moving through 6 key sections today: defining entrapment, causes and mechanisms, clinical presentation and symptoms, specific atypical findings, surgical treatment options, and finally, potential surgical complications.
Section 1. Defining the entrapped ventricle. Okay, so first things first. Also known as an isolated fourth ventricle, this anatomical trap happens when the fourth ventricle loses all communication with its surrounding pathways. Basically, it becomes completely blocked off from the third ventricle above through the Sylvian aqueduct, and entirely bricked off from the basal cisterns below through the foramen of Luschka or Magendie. Think of it like a locked, totally closed room.
Now, here is the core problem. The choroid plexus inside this closed room, it doesn't just turn off, it just keeps producing cerebrospinal fluid. And to give you an idea of the stakes here, a normal brain produces about 500 milliliters of CSF every single day. Because this newly produced fluid literally has nowhere to drain, that isolated space expands dangerously. It acts exactly like a high-pressure water balloon, just blowing up against the surrounding, highly vital brain structures.
Section 2. Underlying causes and mechanisms.
So, statistically speaking, this condition happens in about 2 to 3% of shunted patients. We most commonly see it in 3 very specific groups. Those are patients with a history of chronic shunting of the lateral ventricles, folks recovering from post-infectious fungal hydrocephalus, or patients who have unfortunately endured repeated shunt infections.
The actual physical mechanism here is fascinating. Prolonged diversion of CSF through a lateral shunt actually reduces the normal flow of fluid that usually keeps these anatomical pathways wide open. And this lack of flow allows the delicate ependymal lining of the aqueduct to just sort of rest against itself. We call this prolonged apposition. Over time, as those walls touch, adhesions start to form, literally gluing the pathway shut.
It is also super important to note that we see this anatomical trap occur in patients with Dandy-Walker malformation. You see, if a patient with Dandy-Walker concurrently develops an obstruction of the aqueduct, they too can end up with a fully entrapped fourth ventricle. And that is exactly why strict monitoring of aqueduct patency in these specific patients is absolutely critical.
Section 3. Clinical presentation and symptoms.
All right, so what does this actually look like when a patient with an isolated fourth ventricle walks into your clinic? What are the domino effects of all that expanding pressure?
At a baseline, the steadily building intracranial pressure triggers a cascade of really uncomfortable general symptoms. You're frequently going to see patients suffering from persistent, severe headaches. You will likely notice a distinct loss of physical coordination, or ataxia, really affecting their gait. And gastrointestinally, this mounting pressure often manifests as severe bouts of nausea or vomiting.
But as that enlarged ventricle presses outward onto the highly sensitive surrounding brainstem structures, more specific deficits start to pop up. Patients can actually develop lower cranial nerve palsies. Clinically, this frequently translates to severe swallowing difficulties, which, as you know, isn't just uncomfortable, it presents a massive immediate risk for aspiration pneumonia.
If we trace the path of this pressure, it reveals exactly why certain muscles begin to fail. Direct pressure on the floor of the fourth ventricle physically compresses a structure called the facial colliculus. And when this specific area is squeezed, it directly leads to facial diplegia, which is paralysis of the facial muscles, along with bilateral abducens palsy, restricting the patient's outward eye movement.
Ultimately, if this pressure just continues to mount unchecked without any surgical intervention, the patient's neurological state will critically deteriorate. That ongoing, crushing compression of the brainstem will inevitably lead to a significantly reduced level of consciousness. It turns what was a slow-building issue into a dire, life-threatening emergency.
Section 4. Specific atypical findings.
Now, believe it or not, because the human brain is just incredibly adaptable, an entrapped fourth ventricle is sometimes purely an incidental finding on an imaging scan. Crazy, right? Even if the patient isn't showing severe ataxia or cranial nerve palsies, this finding might be quietly related to highly atypical neurological signs. For instance, something as subtle as a markedly reduced attention span could be the only clue that this internal pressure is quietly building.
Section 5. Surgical treatment options.
The overarching goal here is actually pretty straightforward:
shunt the isolated ventricle. Relieving this pressure can also importantly alleviate associated slit ventricles. That's where the ventricles have actually become smaller than normal due to chronic overdrainage somewhere else. Most surgeons advocate achieving this balance either by placing an entirely separate VP shunt or by taking the new catheter and linking it directly into an existing shunt system.
The usual first choice for surgeons is insertion from below the cerebellar tonsils under direct, highly careful vision. Doing it this way allows the surgeon to accurately place the catheter, bring it out at the dural suture line, and securely anchor it using an angle adapter that is sutured right to the dura. This anchoring stability is absolutely key to preventing the catheter from migrating later on.
Now, a secondary approach involves passing the catheter straight through the cerebellar hemisphere. But surgeons must be incredibly precise here. They literally have to bring the catheter into the fourth ventricle at a slight angle. Why? Because as the ventricle drains and shrinks, the brainstem actually shifts back into its normal position. If the angle is wrong, that newly shifting brainstem could impale itself right onto the catheter tip, causing a devastating delayed injury.
There are two other highly conditional options we should mention. The Torkildsen shunt, or ventriculocisternal shunt, is viable, but only if you are absolutely certain the patient's arachnoid granulations are fully functional to absorb the fluid. And note, this is rarely the case in hydrocephalus with infantile onset. Alternately, a lumbar puncture, or LP shunt, might be considered, but strictly only if the fourth ventricle outlets happen to still be open and patent.
Section 6. Potential surgical complications. Post-surgical cranial nerve palsies are the major risk here, and they usually happen in two distinct ways. First, there's the risk of direct catheter penetration of the brainstem, which can happen either during the initial insertion or as a delayed injury as the ventricle shrinks around the tube. Second, we have overshunting. If the fluid drains too fast, the brainstem shifts posteriorly way too rapidly. This causes a physical traction effect, severely pulling and stretching those delicate lower cranial nerves.
Which leaves us with this final, somewhat provocative thought. Given the incredibly delicate real estate of the posterior fossa and the severe consequences of even millimeters of error, how can the medical field continue to innovate these shunting techniques, balancing the absolute necessity of relieving pressure against the risk of brainstem injury is quite literally the ultimate tightrope walk. Thank you so much for joining me for this explainer. I really hope it brought total clarity to your understanding of the entrapped fourth ventricle.